Good evening, good afternoon, good morning, everybody, wherever you are. A very warm welcome to all of you. It is my great pleasure to welcome you to this ICH educational webinar dedicated to very hot topic, namely state-of-the-art management of Philadelphia positive acute lymphoblastic leukemia. And this is a rapidly evolving field that continues to benefit from major advances in targeted therapies, molecular monitoring, and of course, treatment individualization. And today, we are truly honored to be joined by Professor Robin Foa, who is from Rome, a global authority in the field of ALL and leukemia in general. His pioneering work has helped shape the modern approach, actually, of Philadelphia positive ALL. And his deep clinical insight, research leadership have been instrumental in moving the needle toward more effective and less toxic treatment strategies. He started this journey, I think, more than 25 years ago, and you may have seen his superb review about this topic a few weeks ago in the New England Journal of Medicine. And that was exactly the trigger why the ICH Scientific Steering Committee thought that we need to have Professor Foa with us to celebrate these 25 years of advances in the field of ALL. So this session promises to deliver a comprehensive and practice-informing overview of current standards, emerging data, but also future perspectives. So thank you all for joining us. I hope you will enjoy this cutting-edge scientific exchange. And without any further ado, I leave it to Professor Foa. Robin, thank you for joining us.
So, Mama, thank you very much for the invitation. We are back together, as I would say, because we did one a few years ago. When I'm speaking, I'll try to share the slides. Here they are. Years ago, when in fact we published in the New England Journal the first paper on Ph ALL with a combination of targeted treatment and immunotherapy. So what has happened is that we are celebrating, in fact, I would say 25 years that, well, you said it, so you said it in your very kind introduction. So I'm taking your word that I've actually completely changed the management of this disease. And I think it's worth saying it right up front. We might have some young people in the audience that in the older days, when I was young and you were younger, this was the worst hematological malignancy and maybe even the worst cancer. The prognosis was really desperate. And in 25 years, which is a long time for each of us, but it's a very short time in medicine, the scenarios changed completely. So I put this title here, Ph ALL 25 years later. And why did I do this is for exactly what Professor Morty said, that only a few weeks ago, in fact, on May 15, the New England Journal published his invited review that was exactly entitled like that, Ph acute lymphoblastic leukemia, 25 years of progress. I'm very happy that the New England, the editors accepted to leave the 25 years in the title, because initially I said we just put Ph ALL. I said that's a bit restrictive. Let's celebrate this, I think, important landmark. So I take the slide from another review published in New England 3 or 4 years ago. This just give again for the younger generation. This whole story started back in 1960, up here on the left, when the Philadelphia chromosome was described. And this indeed was the first cytogenetic abnormality associated to a human cancer, which, as you all know, was hematological, I mean, it was chronic myeloid leukemia. That was a turning point over 60 years ago, but a major turning point to show that the cytogenetic abnormality could lead to cancer. I won't go along all these various points that have been important over the years. I'll just point out a couple. Here in 1990, it was shown that introducing the BCR-ABL fusion gene into irradiated mice led to the development of a CML-like disease, obviously biologically very important. And then in 2001, what was then called STI 571 was identified, and this was a specific inhibitor of Abelson. And this was imatinib, in fact. So this is 2001. And that opened the whole story for chronic myeloid leukemia. And obviously, we know that Philadelphia positive ALL has the same genetic abnormality. So at some point, it seemed obvious that we should consider using imatinib in Philadelphia positive ALL. So what happened? I think the background is in this slide, saying what is the story of Philadelphia positive ALL in adults. Before the TKIs came on the scene, as I already mentioned, this was the worst hematological malignancies. I think we should recall that it is the most frequent genetic abnormality in adult ALL, and that the incidence increases with age. So in patients of the age of 50, about 1 out of 2 bilineage ALLs carries the BCR-ABL. So the change has been dramatic. Following the introduction of TKIs, so targeted treatment, this has opened a new era on the management of this disease. The other key point, as in all ALL, not all Philadelphia positive, and already as Professor Morty alluded to, the role and impact of monitoring minimal or measurable residual disease. This is a key point. If we want to cure an ALL, we should obtain with the frontline treatment a status of sustained MRD negativity. Now, the next key step in this story is the introduction of immunotherapy, which is also a form of targeted treatment, and I will discuss this too, but this has been a further pillar in the management of this disease. To an extent that it's fair to say that today, Ph positive ALL is a curable disease. The question may be for how many patients, but I'll give you some data on this. And the advancement has been such that today we're questioning the role of systemic chemotherapy and even transplant. And I think we should recall that before this major change, transplant, I'm talking about allogeneic transplant, obviously was the only potential form of cure for these diseases. So now I think it's fair to say that the chemo-free transplant strategy is today a realistic possibility. I've added also here a final point with the question mark, can we stop treatment? Something that we are all used to in the chronic myeloid leukemia, but this is something we're starting to discuss also in Philadelphia positive ALL. So we're going from the worst condition to a condition where we might stop treatment, and this, I think, is a real step forward. So incidence, I told you, increases with age. Look here, this is an analysis on over 5,000 cases of ALL in Italy on the two databases of the childhood protocols and adults. And you can see, subdividing by age, how the incidence of Philadelphia positive increases. It's very rare in children, as we know, but it's quite rare in the very young adults, and it increases, and you can see the data in the over 50s. So this is one of the pictures that are showed in the New England Review, and this is a timeline for studies on frontline TKIs plus chemotherapy. Because what happened historically is that when TKIs appeared on the scene, these were simply added to the chemotherapy. First, the backbone that was in place, that means intensive chemo, and then progressively it was shifted to lower dose chemotherapy because of toxicity of the combination. And this goes back to you see here there is a the reference all in the paper, in 2000, 2006, the addition of imatinib to intensive frontline chemo, improved response, but increased toxicity. And the same with the second generation TKI dasatinib. Same story, good response, but toxic effects. And in fact, even with Ponatinib, the same story. So many groups, including ourselves in Italy, decided to use lower dose chemotherapy plus TKIs, here dasatinib or nimatinib. And this showed that you can get equally good responses with less toxicity. So this was one important message, that intensive chemo and TKIs were probably too much. So the GIMEMA is the cooperative study group for adult hematological disease in Italy. Now, I think that's important because it's a story of what we've done in the last 25 years. And here it's summarized the GIMEMA frontline strategy without chemotherapy from 2000 to 2025. So these 25 years, obviously in patients with Ph ALL. I don't have time to go through the whole story. If you see it in the review. But we started obviously with Imati, just one piece. This goes back many years, because obviously we did Imati, the first TKI, and we designed a study, you see here in the second column, is for elderly patients over the age of 60. Why? For ethical reasons. Because in those days, this protocol's open in year 2000. So 25 years ago, not to give chemotherapy to a patient with Ph ALL would have seemed really difficult to understand or to accept. But the elderly patients were doing so poorly that many of them did not get chemo at all. We got only palliative treatment. So all ethical committees approved, and this protocol was done for elderly over the age of 60 up to, I think the oldest was 89. And interestingly, all patients went into remission. I'm not saying they were cured, I'm saying they went into pathologic remission. So this opened the whole story that then went to dasatinib for all adult patients over the age of 18, in fact, with no upper age limit. Then this is the third protocol here is an amended protocol because the toxicity of imatinib with intensive chemo, it was changed to imatinib followed by chemo, not concomitant. Then we did a rotation study with 2 inhibitors, then a total therapy study with dasatinib, then we did a study of Ponatinib in the elderly. And that was the induction treatment up to a certain point. Then things changed because from in the second last protocol, this is the D-ALBA study, we decided to go a step further after the induction to give immunotherapy as consolidation. So dasatinib followed, not concomitant, followed by beta-2. And you know the data published. I'll go through them quickly with an update. And then the last study is this one here with Ponatinib plus beta. All have been published, and not here, but in the New England Review. So this again from the New England, and this showed the timeline for study of induction consolidation treatment without systemic chemo in adult Ph ALL in these years. So in 2000, we opened, as I mentioned, the first study for elderly patients without chemotherapy and induction, only imatinib. And then we went along and we showed the rotation of the studies. We did dasatinib. As I mentioned, we did all this. I must say that there's been more than that. We've also showed here that dasatinib and blina in 2021 we published that in the absolute chemotherapy, this could induce also host immune activation. Something hadn't been reported before. We mentioned in the D-ALBA paper in New England, but we had more data in a subsequent blood paper. And so this led to the combination studies, avoiding chemotherapy induction consolidation. This was shown also with Ponatinib. So I'll go through the last study to give you a bit more information. So this was the design of the D-ALBA study. This was for all adult patients, irrespective of age. Now, one key point is here, but I'll talk at the end what is a real life. One key point is that you have to make a diagnosis immediately. And this is not widely available around the world. In theory, the advantage is that you have a steroid-free phase that practically all groups introduced in ALL patients from children to adults. And in this more or less week of steroid-free phase, you should test if a patient has a BCR-ABL. This is what we do centrally in our studies. So in this protocol, all the patients received dasatinib, induction plus steroids. And at the end of the study, across the board, all patients, irrespective of depth of response, even patients complete molecular response, all received blinatumomab. for a minimum 2 cycles, but they went up to 5 cycles. And the primary endpoint of this study, of this particular study, was the rate of molecular response after 2 cycles of blinatumomab. And I would add that the post-consolidation treatment were left open to the centers, but we accumulated all the data in an ancillary GIMEMA protocol. The only chemotherapy was in the CNS prophylaxis, which is obviously mandatory for these patients. Now, this paper was published in October 2020 in the New England Journal. I don't want to go into detail, but the response is very good, with good molecular responses, and the early data looked extremely promising. Here, the molecular response, a couple of points here. You can obtain a molecular response even only with a TKI, dependent TKI, not with maybe with imatinib, but dasatinib. We had in this study at the end of dasatinib 29% of molecular responses. Molecular means quantitative PCR. And we've seen this in another study too. About 30% of patients obtain a molecular response. After 2 cycles of blina, up to 60%. And after more cycles, the rates of molecular response increase further, something we hadn't seen before. So that was a starting point. Now, as you know very well, sometimes the first study gives great results, the follow-up may be less brilliant. So this is a follow-up of the study that appeared online in December 2023 in the journal Clinical Oncology, and this had a median follow-up of 53 months. And you can see that the survival rates are looking very good, between 75 and 80%. And I would add with a plateau, which appears to be visible. So we are very rewarded by seeing that at the long-term follow-up, the data remain extremely positive. A lot of biology in our study. I'm not going through all this, it's published, but a couple of points. One is this, on the left panel, you see this, the upper line, which is a complete line. These are patients who obtain the early responders. Those are molecularly negative after induction. So far, none of these patients are relapsed. So the early responders, the ones who are doing better, as many groups, including ourselves, but others too have already reported with, and a bit like in CML too, the early responders. Icaros Plus, it's a genetic profile you have to study at diagnosis, is something that in this study maintains an unfavorable prognostic profile. So this means that these patients should probably be transplanted. Now, what happened to this patient? It's in the JCO paper. Just to remind ourselves that 29 patients continued treatment only with a TKI, 24 underwent a stem cell transplant in first remission, 6 in second remission. Now, of the 29 patients who did not receive systemic chemo or transplant and continue only with a TKI, 27, that's 93%, had obtained a deep molecular response following treatment with dasatinib and blina. So I would say this was a wise decision by the center. Maybe we were consulted, we discussed it together. But if you obtain a sustained molecular response, it seems wise not to give chemo and transplant. And of these 29 patients, 28, that's 96.65%, remain in persistent remission only on TKI treatment. So this strongly indicates, it's indication that the design of the study was not tailored to answer this question, that you can avoid chemotherapy and transplant. Now, if we put together the data of the study, we can say that there's the 4+ year follow-up of the study indicates that the chemo-free induction cessation approach is feasible at all ages, is associated with low toxicity. It reduces a marked immune modulation. I did show you this, it's published. I'll come back to this in a minute. It translates into very high rates of molecular response and survival rates. And as I've mentioned, 50% of patients have been managed only with TKI and blina. I don't have time to show, but it's in the last paper, in the second last paper. Transplant has a clear impact in MRD positive patients. So most of the MRD positive patients were transplanted, and this was a good decision. Incidentally, transplantatory, this paper published earlier that if you got patients obtain a very profound early molecular response, transplant may be spared. This is from the MD Anderson. So then we designed a study, which is the first randomized study in this specific setting. This phase 3 study with 236 patients, all adults, no upper limit again. It's a random 2-to-1. Experimental arm is Ponatinib and Blina. Conventional arm is imatinib and chemotherapy. Why imatinib? Because this was at the time, and largely still is, the only TKI available worldwide for Philadelphia positive ALL. Now, it was a 2-to-1, as I mentioned, and a crossover was planned to the experimental arm if patients remain, if patients remain MRD positive. Now, here, transplant is part of the study. Transplant allocation is based on MRD levels. This means that if patients are MRD negative, sustained, then these patients, and don't have Icarus Plus in particular, these patients are not transplanted, even though they're 18 years old and have a sibling donor. A lot of biology associated to the study. We were doing not only monitoring on B-cell receptor, but also immunoglobulin and T-cell receptor genes, and not only quantum PCR, but also digital droplet PCR. And the immune system has been monitored with Ponatinib, but we didn't have any information on this with this combination. Now, the enrollment was completed in January, and we are accumulating data, but Sabina Chiaretti from our group presented this orally at ASH in December, and these are the data on the patient in experimental arm, 151. I don't want to go into many details. Crossover was given to 35% of patients because of MRD positivity. And here I'll show you the molecular response to make a long story short. Now here you see them in red here, end of induction. That means at the end of the Ponatinib steroid induction, we went up to 46%, remembering that with Dasatinib it was 29%. And after 2 cycles of Blina, same primary endpoint from 60 to 74, which at the last analysis slightly higher. So the responses seem to be more profound earlier with Ponatinib, as expected based on preclinical data. Now, these are the curves that Sabina presented at ASH. Obviously, early days, the median follow-up is short, but you see the curves are looking extremely promising. We are updating this. I'll mention this in a few minutes. And what is interesting, and we presented this at ASH, that the complete molecular responders, the ones with not complete molecular, still with a signal, so far are doing similar to patients with a complete molecular response. If this holds true, this would be an advantage compared with what we had seen, and I showed you with Dasatinib and blinatumomab. Now, the conclusion that we could draw at that point was that the combination of Ponatinib induction followed by Blina seems to be further improving the results achieved in the D-ALBA trial. This appears to be so in terms of early molecular response. As I showed you, strategy is effective and feasible. You saw the overall survival and disease-free projected 12 months of 95%. And the side effects have been acceptable, and despite Ponatinib being more toxic than Dasatinib. The biologically driven allocation of transplant has further reduced the rate of gallbladder. At the time of the analysis for ASH, only 10% of patients went to transplant. That's very low compared to what we would expect. And based on results, a strategy of TKI discontinuation after an opt-in time on TKI needs to be considered. I mentioned at the beginning, and I think these data go always more in that direction. Now, the MD Anderson has done the same with Ponatinib and Blina, but they give it together. It's not sequential. Ponatinib, Blina is associated. And here's the update of the study in the JCO in July last year. Now, they enrolled 60 of the 95 patients, so there was not all patients were considered eligible. In fact, 35 were not considered eligible, and it's a report in a paper reason for this. I want to point out another point that 39 of the 60 patients had untreated disease, while 21, which are 35%, were already in remission at the time of entering the study. So they were not really in first-line treatment. They received 1 or 2 courses of chemotherapy, were in remission when they went to Ponatinib and Blina. Here are the curves that are in the paper, and they look promising. They've seen 7 relapses at that time. Isolated CNS relapses, maybe in discussions might come up. I don't know. We will see. Can we stop treatment? I mentioned a couple of papers indicating this. MD Anderson suggested this. We did a study, a retrospective study, so nothing prospective. These are patients for different reasons, 18 patients, for different reasons stopped imatinib. It might be individual decision toxicity, medical decision, whatever, not prospective. 17 of these 18 patients were in molecular response when they stopped treatment, so good reason. 5 of these 18 patients, 28% of the molecular relapse, 4 restarted TKI and regained the molecular remission, similar to what we see in CML. So that's something to keep into consideration. And you can see that the long-term survival data look extremely promising. But as I said, this is retrospective, so it is limited in value, obviously. And this was published in Hematology very recently, and also in How I Treat by Sabina and myself in Blood. So I mentioned immune modulation. So we conducted, or we are conducting, a study comparing the immunomodulatory effect of dasatinib versus ponatinib in newly diagnosed patients. Now, this was presented orally by our young collaborator, Michela Swinelli, in December dash. And it seems that in adult patients positive frontline treatment, with dasatinib induce a more profound NKT and KNT-reg immune modulation compared to ponatinib plus blina. Now, when this was seen even in the bone marrow, NKT cells showed increased level of activation in the dasatinib cohort. So it appears to be more immunomodulatory than the dasatinib combination. Now, this may not be surprising, but if you remember data with dasatinib in chronic myeloid leukemia, there are many studies in the past showing an increase in NK cells, LGL cells, lymphocytosis. So dasatinib has this capacity. So I think this is an interesting observation. Remember that this is obviously in the absence of systemic chemo. So the marrow of these patients or the immune system has not been deteriorated by chemotherapy. I think the last sentence is important. I think the long-term follow-up of the ponatinib study will clarify if the lower post-immune modulation compared to dasatinib is counterbalanced by the more potent anti-leukemia activity of ponatinib with a lower relapse rate. So this is a question for the future. We don't know yet. Now, here you can see some data. You see in red is dasatinib, in blue ponatinib. See more lymphocytes in dasatinib, and particularly the Tregs are reduced more markedly with dasatinib. Now Tregs play an immunosuppressive effect, so this is good news. And you can see the NK cells are much higher in dasatinib as also the TNK. So we are completing the study. We presented, but now we have many more data, and we're sending the paper out now. And I finished. I'll tell you one more thing. I mean, we are updating the ponatinib studies. We'll send an abstract to ASH, and we hope to report in the summer, send the first paper comparing the two arms of the study, experimental and the control arm, because we finished induction and we have the data, and we'll write it up very soon. So the final two final points I want to make. Here I put all the data together, and again, it's in the figure in the New England. Look here, I mean, this is on the top, it's overall below disease-free. Now, the bottom lines are pre-TKI. This is what we expected in the old days. But the old days were 25 years ago, not 2 centuries ago. So this is what the outcome before TKI was. And then it's improved with the first TKIs, and here we start with the addition of immunotherapy. This is the D-ALBA, and these are the first data of the last study. So I think this is the most important of what we've seen so far. As I said, for last study, early days, but it's looking extremely promising. So that is a reality today. But I put this because I wrote about this also in the New England. I think we have to be very aware that we're facing an ideal world versus real life situation. It is clear that this targeted immunotherapeutic strategy is capable of reducing systemic chemo, transplant, and overall hospitalizations. Because, I mean, TKIs you give orally, so they can be given partly at home. And I added also here that blina has been developed in sub-Q formulation. There are a couple of published papers, and this is going to change further, I think, the management, make it much more feasible and largely out of the hospital. However, the above is doable in setting of ad hoc design clinical trial with central handling of biological material, because all this requires quick diagnostic workup. It requires MRD monitoring. It requires that we identify if it has an unfavorable genetic profile. We should look for mutations of the ableton if we have residual disease. So a lot of biology should be associated to these studies. I put here that the diagnostic workup for the BCR ableton in 1 week from diagnosis is too often not available. And I would add, not tested often in elderly old patients. I mean, how many over 75, 80, 85-year-old patients are tested for the BCR ableton around the world? I would say a large minority, when we know that if you give a pill, these patients can be put into remission. Icarus Plus is very often not investigated. DAS and Ponatinib are often not available for frontline treatment. In most parts of the world, this is the case. We have a problem too in Europe. Standard molecular MRD monitoring is frequently unavailable outside of clinical trials. Blina is not approved for MRD negative Philadelphia positive ALL patients. In fact, in Europe, it is not approved by EMA, even for MRD positive adult Ph positive ALL. So we're facing a serious problem. This approach is possible out of pocket. I put this quote unquote in some parts of the world. Obviously, this is a very unfortunate situation, but this does happen. So what is happening is that in the real life, most patients are still treated with the available TKI plus chemotherapy, mostly the intensified followed by transplant. So these are my thoughts, and I put this in New England, and a nice figure has come out. They redesigned them and do a better job than certainly I did. So here, the recommended real strategy for frontline treatment of all ages of Ph point. So this is a recommended strategy. 1 week pre-phase CFF patient has the BCR ableton and investigate for the Icarus profile. Then the induction, I put ideally dasatinib or Ponatinib with steroids. End of induction, MRD monitoring should be done correctly. That is a key point, not in-house if possible. Consolidate with blinatumomab and MRD monitoring. Now, what happens? If a patient is sustained negative molecularly for MRD and Icarus negative, then I think a patient should continue TKI and simply be monitored for MRD. If a patient MRD positive or Icarus Plus, or one of the two or both, then I think a transplant should be offered to the patient, then TKI and close MRD. So this would be, for me, the reality, the ideal world. Unfortunately, we have to go to panel B with the real life. So we might manage to do the BCR diagnosis, but we will, what will you use? The available TKI. In most parts of the world, this will be imatinib. And at that point, they will get chemotherapy, either together or consolidation. Mostly, as I mentioned, it'll be low-dose chemotherapy. MRD, is it doable or not doable? Now, if it's doable, and you trust on who has done it, because that's another point, if patients become MRD negative, I think maybe you could go to maintenance treatment plus TKI, but still maintenance treatment and continue with that. If a patient MRD positive, transplant should be offered to this patient. If MRD is not doable, then I think transplant should be offered to the eligible patients and further TKI. So ideal world and the real life. Unfortunately, even here, the right panel is bigger, but it's also the numbers are much bigger on the right panel. So I think I'll finish here because I think this ends the story. Then we can maybe discuss. Obviously, I would have hundreds of people to thank because, as I told you, this started. In fact, I'll say one more word. We started talking about giving imatinib to these patients with Michele Baccarani, who unfortunately no longer with us, and he was a great expert in CML. And I remember at a meeting, and I put this in the acknowledgement, because it's a true story, at a meeting somewhere, I think in Bologna, but I don't remember. This was the end of last century, or last millennium, if you want. We started considering this possibility, and this led to design a study, which then led in 2000 to open a story. So I would have to thank thousands of people, because thousands, but hundreds of people definitely. I'll just thank obviously the GIMEMA centers, all the patients and families, the GIMEMA and the funding. I mean, for us, for me in particular, it's Italian Association Against Cancer. I've been supported for 25 years, and without them, all this would not have been possible, because the situation in the public sector is not easy and the funding is never sufficient. So, Mohammed, I'll stop here. Here we
Thank
are.
you.
I can see you again.
Thank you very much, Robin. This is really an incredible webinar, but also it's an incredible story. And what a pleasure for a research physician scientist like yourself, starting your career with a terrible and deadly disease, and now seeing it being cured with a few pills and an IV Blina. This is amazing. So we do have a lot of questions, Robin, if you can spare a few minutes.
Sure, sure, I'm
I'll
here.
try to structure them into uh, uh,
Not too
so,
difficult.
so you mentioned that 10% may still need allotransplant. We have a question here. Can you please expand a bit on this and how to identify these patients? This is from
Yeah,
Dr. Dereen.
yeah. Well, I mean, that is preliminary data from the last study, as I mentioned. So it's preliminary. But however, that's already much lower than what we saw with the D-ALBA. But again, I would like to stress once again, the D-ALBA was not structured to answer the question of chance, but the numbers were too small. We obviously analyzed and we published the data, but the numbers were too small. Having said that, as I told you, about half of the patients went to transplant. In the preliminary data in the Ponatinib study, it appears to be low, but it's preliminary. So, I mean, I can't be too firm on this point. As I said, we are reanalyzing now. We'll send an answer to ASH. So I have some data, but we're still analyzing, so I shouldn't talk about it right now. But surely the numbers are going down. Which patient? I think I said it at the end. I think MRD is a key point. If a patient remains MRD positive, I still think this patient should go to a transplant. And the Icarus Plus, so far, these patients should go to transplant, even if they're MRD negative, I would say. Again, in this last study, we will see if that holds true. Based on the D-ALBA, we would indicate, and that we put in design a study of patient Icarus Plus, this patient should go to transplant, even if MRD negative.
So we have a question here about the ALBA study, actually. Is there a specific cluster, biological or genetic phenotype of patient who did not achieve a response in the ALBA study?
Well, I mean, they all went into remission. I think it was 98%, so not hematologically. I mean, one of the key points there, I showed you that the MRD negative patient, the early MRD negative, let's turn it around. The early responders so far have never relapsed, have not relapsed at a long follow-up. So the early MRD negative patients after induction of those are doing better. Having said that, even the ones who are MRD negative, they're 70% of long-term survival, so they're still doing well, but less well. And the Icarus Plus are doing less well. That is very clear. I don't know yet in the new study, because we haven't analyzed the data yet, if the Icarus Plus are doing better with Ponatinib. So that I don't know. So I would say the Icarus Plus and MRD are the two factors that are affecting the outcome in the D-ALBA. I don't think I can comment on immune modulation, because I don't know if we can, numbers are too small. I think the next step will to see if the immune modulation correlates with long-term survival.
Wonderful, thank you. We have a question here about the mutation status of IKZF1. How do you handle the unfavorable status here?
Well, the first point is how do you detect them? Because, I mean, as you know, it's not easy to detect the Icaros. We set up and published a system with 10 genes, which seems to be highly reliable. So these patients, if we identify them and we can, they go to transplant, as I mentioned. So this remains an unfavorable factor, and the transplant should be offered to the patients if they're eligible, obviously. As I said before, I don't know in a new study, I hope to know soon, but I don't have the data yet. Don't want to tell you, but I don't have them. If they go as badly as with Dazati and bleed, that I don't know. You know, I'm very keen, and I would like to stress it again. I was very surprised by the immune modulation, but I think it's something extremely interesting. I mean, I've worked on lymphocytes, on immune cells for years and years, starting in CLL, in fact, in London, let's say many decades ago, and working on the immune system of CLL, not on the leukemia cell. And I think it's very interesting to see that in an ALL, you see an immune modulation driven by treatment in the absence of chemotherapy. Now, how much that works on a control of the disease, we don't know yet. We are testing long-term follow-up patients to see if this persists over time. But I think that could be a very interesting piece of information, and we'll have to see, as I mentioned at the end, if the lower immune modulation with Ponatinib is counterbalanced by the more potent anti-leukemic effect. So we don't know. I mean, if somebody asked me now, are you sure that Ponatinib is better than Dasatinib? I would say I don't know.
So in line with the immunomodulatory effect you've been describing, and I guess one would need a good immune system if you're using a T-cell engager like blinatumomab. So do we have an idea about the immune status in these patients at baseline? Is it quite homogeneous or are there differences? And we have another question here from Dr. Panizo Irene, whether any immune monitoring is needed in these patients at a given time point.
Well, for the first question you made, Mohammed, we don't, I mean, you know, patients come in and they have blasts everywhere. I mean, so it's very, I mean, I don't think we have data really. I mean, even 30 years ago, this was done, but we have no firm data saying that the immune system at diagnosis plays a role. It depends if they have 90% of blasts in America, 30%, so it varies a lot. So we are not doing it. We're doing it after treatment. I think it's important to note that we are giving the T-cell engager, the blina, after when they're in remission. So this is a key point. We're not giving concomitantly. So we give the TKI, and as I don't know if it was in the slide, maybe it said, in all our studies with the TKI in induction, the rates of hematologic response is between 94 and 100%. So like we can say that virtually all patients go into remission. So when they start the blina, I mean, I imagine the immune system has been restored. And in fact, we see that they have NK cells, they have T cells. What is interesting that these are upmodulated further by the TKI, particularly Tazati. And the Tregs go down. And already Top had shown that Tregs, not Top, well, I think it was, in a leukemia paper, that Tregs play a role in blina. So it all makes a certain degree of sense. Now, what should we monitor that? I mean, the question somebody asked is, should we monitor for immune system? That is a difficult question. I mean, we don't have clear data that this affects treatment. We are doing it because obviously it's a scientific question and it's certainly interesting, but I think it's early to say that we should include an immune monitoring in all patients. I mean, with you, we are talking before on the resources, on the difficulty, everything. So I think we have to optimize also resources, which are getting dreadful everywhere, personnel. So I think we should have to see what should we do. Let's identify the BCR-ABLs. Let's try to give the drug. Let's do MRD, at least that. These are the key points, and the ECRs, obviously. The rest is researched at this point. I say, if we can do it, we'll do it. In the next study, we may not do it because who's going to pay? Let's be very open. We work in a public system. The two of us do, at least. We are not in some other part of the world.
Absolutely. And actually, by the way, we're very proud working in the public system and trying
Absolutely,
to
absolutely.
advance this field. Dr. Monica Kulasekaran, I hope I'm pronouncing it correctly, is asking about the T315 I mutation, which we know from
Yeah.
CML, whether there is a role for asciminib in Philadelphia positive ALL.
Yes. Well, listen, I mentioned this. If you look at the review, I mentioned that too. I think to be very open and immediate, I think we have too few data of asciminib in Philadelphia. There are some preliminary data, some evidence, but not enough. In fact, I remember when the study was conducted, the protocol was opened for CML. It was also allowed to include some Ph positive, some relapsed Ph positive ALL. Data were not that brilliant. So I think it's too early to actually say that that may have a strong role.
Another question here from Dr. Nayak, whether if using chemotherapy for whatever reason, Blina is not accessible, would you prefer with chemo, DAZA, imatinib? And we have a few other questions about the different TK inhibitors. Do we have a hierarchy there, or you would rather take whatever you have?
Yeah, again, I'd be very practical, Mohammed. I think, if I had to choose, it would be a second or third generation. Certainly either dasatinib or ponatinib. Ponatinib is more potent. I mean, I showed you the data that the molecular responses are higher. In fact, now the last update, we were close to 80%, so it's higher than with dasatinib. On the long run, we don't know. The curve at 18 months, this is out of context. I'm not saying it, but I say it. They seem very similar between two protocols. So we have to see on the long term. So, it very much depends on what you can put your hand on. We are in a situation, I'll give you in Italy. We can't do a study now because dasatinib is not approved frontline, no ponatinib. No, ponatinib is in a special session, you can get it, but you're not allowed to do a study. So we cannot give dasatinib, ponatinib plus sub-Q blina would be our study, and I'm just give it because they won't, we don't have the TKI. So now we're trying to buy one. So, I mean, I think it very much depends on the reality where you live. But I would certainly go with a second or third generation, followed by Blina. That would be, with no doubt, my choice. The mutations. Now, mutations, as you know, with dasatinib, you do have relapsive mutations. We published this, and all the groups have seen this. We shouldn't see them, or should see them much less with ponatinib. But we'll have to see. I mean, Ponatinib is a bit more toxic, so we have to, I think, balance everything before deciding what is best. Obviously, patients have to be monitored for the mutations. I would add, I think I mentioned it in a discussion, we do the monitoring even on MRD, because a patient had the mutation on the MRD part, that would be good reason to change the inhibitor and go to third generation.
Thank you, Robin. I'm glad you mentioned, of course, the reality of the world, and not everybody is in rich countries. And we at the ICH, we always advocate for the AAA, availability, accessibility, affordability. And we have a question here from Dr. Flor Maria Armias Canseco, asking whether you believe short courses of blinatumomab plus a TK inhibitor is a good approach in countries with resources constraints, trying to save some money.
Yeah, no, that's a good point. I mean, again, we don't have data, so I can't give you any firm answer. I can add that we even tried to give further cycles of bleed after the 5, maybe as maintenance, but the company was not interested in that. And I strongly believe that we will manage most patients without, if we can, in an ideal world, only with the TKI second, third generation and Blina. I think we have to see what is essential, what is the minimum. I mean, you know better than I do that the time that goes from developing a molecule to the clinic has become so quick. I mean, I remember years ago that even rituximab was it was given at 375 multiple of 125. It worked, and that was it. And then years later, it was shown that lower doses were equally effective. So, I mean, the push to get the drugs on the market is very strong. So we don't exactly know how much you need. the dosing you need. So I can't answer, but we have no data on this. It could be that low doses could be equally effective. I know that this has been done because, as a colleague correctly said, if you have a certain number of vials, you may want to divide the vials between more patients. I mean, which makes sense. Scientifically, it's not correct, but we have to be realistic. If you have two patients, yeah, and you can't give, better to give half to each or give the full dose to one. That's a difficult point. Very difficult.
We have one provocative question here. Despite the great result you showed with Blina and TK inhibitors, the question is, why don't we give one course of induction a diagnose and then consolidate by a single shot CAR T cell? I guess there is a Chinese protocol like this.
Yeah. Yeah. Okay. I'll answer with another provocative point. Nothing wrong in that. I mean, it's very difficult to improve on data in the Philadelphia positive. So I wouldn't change if I got it. But what about the Philadelphia negative? So I tried at least 3 or 4 years ago to convince at least a couple of companies, say, listen, why don't we do a very small protocol in elderly patients with Philadelphia negative B lineage ALL? 75, 80, 85. I mean, the median life now is up to 85, 90. Why should you not treat them? You give them exactly what this colleague said. Mild chemo, one course, and then CAR T cells. It seemed so obvious to me. I tried and I failed. No company was interested because of small numbers. It's a usual story. So I agree entirely. Not in the Philadelphia. I would never do that in the Philadelphia because of the data that we discussed. But in the Philadelphia negative, why not in yellow? Why should we give chemo and give only toxic? Give one debulk and one CAR T cell. Definitely. I fully agree. But we
One
didn't
last
manage to.
question, Robin, because now you have dozens of patients with long-term follow-up, and I think this is a very relevant question because obviously our goal is to cure these patients to allow them to live long and well without long-term complications. And the question we have from the audience is about whether you've seen over the long term some significant long-term complications, especially risk of MDS.
Yes, that's a good point. But to be honest, I've asked the GIMEMA to have a further follow-up of the D-ALBA study because I think the median follow-up now is over 7 years, or around 7 years. So obviously all the side effects and the late complications and development will be analyzed there. So far, this hasn't come up, but we will investigate it further. It's obvious that in this disease, the fact that in the Philadelphia with talking about secondary complications is amazing for people like me who saw what they used to do in the past. Now, it's interesting because the fellows in the clinic say, oh, patient lucky he or she has a Ph positive ALL, which was in the old days was a death sentence. This is reality.
I wouldn't say lucky, it's a
No,
better disease.
yeah, no, they say lucky. No, they say it, not that we say it. To say how it's changed completely. But I mean, I've put together data on a number of patients who were diagnosed in 70s and 80s, and luckily they were tested for the BCR-ABL, and I've got 4 or 5 who've been treated only with a TKI, and they've lived 5 years, 10 years, 15 years. One has turned 90, 2 have turned 85. But that means go back again to the accessibility to lab testing, even not only drugs, because imatinib is not expensive. You can give that. You can give a generic. You can give it home, but you have to test. So an 8-year-old should be tested, and that. So I'm putting some data together on that too, because I think it's very important to see that the elderly should be adequately managed. Maybe I'm getting old too.
Wonderful. On behalf of the ICH, I'd like to extend our sincere thanks to Professor Robin Foa for this outstanding and insightful presentation, but also a very exciting discussion on the state-of-the-art management of Philadelphia positive ALL. As you have noticed, the therapeutic landscape of Philadelphia positive ALL has been transformed radically by the integration of targeted therapies, chemo-free regimens, but also MRD guided strategies, offering new hope for deeper remissions and, of course, improved long-term outcomes. We look forward to continuing these important discussions and to further advancing care through global collaboration and education. Thank you all for joining us today. This is the ICH across the globe and across the hematology field. Thank you.
And thank you, Mohammed. See you somewhere.